Hello everyone. Today we're going to talk about hepatitis viruses. Okay, so let's start first with the first hepatitis virus, which is hepatitis A virus. And as you can remember, it is a picornavirus, so it's an RNA virus, the picornavirus family. And picornaviruses are naked viruses. As you can remember, that from the mnemonic that you have to give CPR to a naked hippie. So CPR, so the P for picorna, and this virus can be transmitted fecally most commonly because it doesn't have any envelope. It is not susceptible to gastric acid, and very importantly, it doesn't have any carrier state, unlike the hepatitis B and hepatitis C, and it has a very short incubation period. The patient can be asymptomatic or can develop an acute hepatitis. And if the patient develops an acute hepatitis, you will find IgM against hepatitis A virus. And if there was a prior hepatitis A infection, or if the patient is vaccinated with the hepatitis A vaccine, the patient will have IgG in the blood. And hepatitis B virus is a hepatnavirus, so it's a DNA virus. So you can remember from the Hep B, so the first age is first stage is herpes and second age is hepatna. It's a DNA virus, and it has to be transmitted by direct contact, maybe parenteral, sexual, or parental transmission. And there is a carrier state, especially very important for hepatitis B and C. Incubation period can be from months, and there is increased risk of hepatocellular carcinoma, very important to know. So two hepatitis virus that increase the risk of hepatocellular carcinoma are hepatitis B virus and hepatitis C virus. And one important thing about hepatitis B virus is it has a DNA polymerase which has both DNA and RNA dependent activity. So the DNA dependent activity actually completes the partial dsDNA genome of the hepatitis B virus, and after transcription, the mRNA will form viral proteins, and this all will be done by the host genes, host proteins such as host RNA polymerase and host ribosomes. But later on, this RNA will be again converted to DNA by the reverse transcriptase activity of the DNA polymerase. So RNA dependent DNA polymerase, and this will lead to the formation of the genome of the progeny virus, which is actually DNA virus. So this is very important. Hepatitis B serology, very important for your clinical life especially. So we have actually 3 antigens and 3 antibodies. So we have the hepatitis B surface antigen, we have the hepatitis B core antigen, and we have the hepatitis B E antigen. And among those 3 antigens, we measure actually the 2, HBsAg and HBeAg. And we have 3 antibodies against them: anti-hepatitis B surface antigen, anti-hepatitis B core antigen, anti-hepatitis B E antigen, and we measure all of them. So we have actually 3 antigens, 3 antibodies, but we measure 2 antibodies and 2 antigens and 3 antibodies. So totally we measure the 5 among those 6 serological markers. So the first one that we measured for the screening purpose is hepatitis B surface antigen. So it's actually indicative of hepatitis B infection, but it cannot tell you if it is an acute infection or a chronic infection. And the antibody against hepatitis B surface antigen, which is anti-HBs, is a very protective antibody. If it if it is produced in a patient's body, it will actually protect the patient from hepatitis B. So it's very it protects the patient. And another antigens is hepatitis B core antigen. It is not actually measured. What is measured is the antibody against the core antigen, which is anti-HBc. It's very important. This is the most important hepatitis B serologic marker that you need to remember. So this can be, if in case of an acute infection or a recent infection, you can have an IgM against the HBsAg, or you can have an IgG, which will actually tell you that the patient may be exposed previously or the patient is having a chronic infection. And very important is to know that IgM against the HBC core antigen or anti-HBC may be the sole positive marker of infection during the window period. So window period is the period during which the HBsAg disappeared and the anti-HBs still not appeared. So in this period, anti-HBC IgM can be the sole marker. So that's why it's very important to do an anti-HBC IgM in window period. Okay, very important. And HBeAg is actually an antigen which indicates active viral replication, and if the virus is replicating very actively, the viral DNA copies will be very high and it will lead to a high transmissibility. So if there is formation of antibody against the antigen, it will actually indicate a low transmissibility. So anti-HBe will indicate a low transmissibility. So here we have a graph to show us. Here we have the titer on the y-axis, and the x-axis we have the months after exposure. So we have different markers. One is hepatitis B surface antigen, what we use actually for the screening purpose, and you can see later on the hepatitis B E antigen can also be found. But there is a period which is called window period when the HBsAg is no longer detectable and anti-HBs is has still not appeared in the blood. So during this period, the most important marker is anti-HBc, most likely IgM. So anti-HBc IgM, especially for the window period right here. And the HBeAg appears after some time, after disappearance of HBeAg, which will indicate a low transmissibility. So again, we can recap: HBsAg for screening purpose, HBeAg to see for the replication status, and anti-HBc to confirm during window period, anti-HBs to see if the patient developed an immunity against the hepatitis B virus, and anti-HBe to see if the transmissibility has become low. Okay, so this is the basic idea of the hepatitis serology. So here again, there are different kind of patients, and we can see different kind of markers in those patients. So if someone gets an acute hepatitis B virus infection, the first test we do an HBsAg, and it will be positive. And as the acute cases have a very high replication rate of the virus, it will have a positive HBeAg. But the antibody is still not formed, so there is no anti-HBs and there is no anti-HBe. But the anti-HBc has already formed. And if the patient is in window period, the most important marker in that period is anti-HBc, because you have a disappearance of the HBsAg and the anti-HBs still not appeared, and also you don't have any HBeAg. And if someone has a chronic hepatitis B virus infection, now you want to see the infectivity. So if you want to see the high infectivity, the patient will have a positive HBeAg. If you see a presence of an anti-HBe, it will indicate a low infectivity. But in both cases, you will have an IgG against the hepatitis B core antigen. So IgG, anti-HBc. And if the patient had infection in the past, but now the patient has recovered from the infection, that would mean that this patient has developed antibody against surface antigen, so anti-HBs. So the anti-HBs will protect the patient and will cause the recovery. But still the patient has the IgG against the core antigen, so anti-HBc IgG. But if a patient is only immunized, you immunize the patient with hepatitis B surface antigen, which is the subunit vaccine. And if you give that vaccine, it will stimulate the production of anti-HBs only, which will protect the patient from further infection. So that's all about the hepatitis B serology. And hepatitis C virus is a RNA virus, and it's a flavivirus, and it's commonly transmitted through dialysis and also transfusion, and there is a carrier state, very important. Incubation period is long, like the hepatitis B virus, and most importantly, it also increases the HCC risk. And both of the hepatitis B and C virus causes the chronic liver disease, especially in the poor countries, in our developing countries. And one of the important markers for hepatitis C virus is anti-HCV. And we can treat hepatitis C virus by multiple drugs. One is ribavirin. So ribavirin actually inhibits the synthesis of guanine nucleotides by competitively inhibiting the inosine monophosphate dehydrogenase. And we can use the ribavirin in chronic hepatitis C virus, and also you can use in respiratory syncytial virus. But in case of babies, we actually prefer to use palivizumab, which is actually anti-F or anti-fusion protein monoclonal antibody in children to prevent respiratory syncytial viral induced pneumonia. And ribavirin actually can cause hemolytic anemia as a toxicity. Another drug for hepatitis C is cimeprevir, which is actually an inhibitor of hepatitis C virus protease, and it actually prevents the viral replication. So you can use it in chronic hepatitis C virus in combination with ribavirin and pegylated interferon alpha. But you shouldn't use that as monotherapy. That's important to note. And also, it can cause photosensitive reaction and rashes in the patient. Sofosbuvir is another new drug for hepatitis C treatment, and it inhibits the hepatitis C virus RNA-dependent RNA polymerase, and it acts as a chain terminator. So you can use it in chronic hepatitis C virus along with ribavirin, with or without pegylated interferon alpha. But like cimeprevir, you shouldn't use it as a monotherapy, and it can cause some complications or toxicity symptoms like fatigue, headache, and nausea. Hepatitis D virus is an RNA virus, a delta virus family, and it can be transmitted like the hepatitis B virus, which is parenteral, sexual, and perinatal transmission. And also it has a carrier state like the hepatitis B and C virus. And it can be super infected, so maybe someone had a hepatitis B virus infection, and right now he again got infected with hepatitis D virus, so it's called super infection. And in this case it will have a short incubation period because the hepatitis B virus has already infected the patient past its incubation period. Now it's actively replicating, and it's providing the hepatitis B surface antigen which is needed for the replication of hepatitis D virus, and that's why it has a short incubation. But if the hepatitis D virus infects the patient along with hepatitis B virus, it will have a long incubation, because hepatitis B virus has a long incubation and hepatitis D virus is dependent on hepatitis B virus for its replication. So co-infection will have a long incubation period. And hepatitis D virus also increases the hepatocellular carcinoma risk like the hepatitis B and C virus. And it's actually, as I have already mentioned, it's a defective virus dependent on hepatitis B virus to give it the hepatitis B surface antigen. And if it causes superinfection, it will worsen the prognosis of a already hepatitis B infected patient. So that's all from me about hepatitis D virus. Now, hepatitis E virus, which is also an RNA virus and herpesvirus family, and it can be transmitted through fecal-orally, and also it's waterborne disease, and actually from water sources that maybe patient drinks some water and gets from the from the oral cavity, it goes to the stomach, and it's not destroyed in the stomach because most likely it's not a envelope virus, it's a naked virus, and that's why it can be infected in fecal-oral route, and there is no carrier state. And also it has a very short incubation period like the hepatitis A virus, and also it doesn't cause any increased risk of hepatocellular carcinoma. So you see there are multiple similarities between hepatitis A and E virus. And very important thing to note about hepatitis E virus is it can cause severe or fulminant hepatic failure in pregnant women and can lead to death. So high mortality in pregnant women. One mnemonic to remember for hepatitis E virus is it is enteric, may infect expectant mothers, and may cause epidemic due to as its waterborne nature. Okay, so thanks for watching my video. That's all about the hepatitis viruses, and stay tuned for more. I will make a presentation on HIV virus in a very short period of time.